pedir a gentileza de todo mundo que não estiver participando da apresentação deixar o microfone e a câmera silenciados, tá bom? Para a gente não correr o risco de ter nenhum distúrbio aí durante a apresentação, tá? E hoje a gente tem o prazer de ter com a gente aí um grande amigo, um grande expoente aí da nova geração em lesões complexas de joelho, que é o Jorge Chala. Hoje em dia ele trabalha na Midwest Orthopedics at Rush, em Chicago, e ele vai falar um pouquinho sobre lesões de raiz, tá? Lesões radiais, a gente vai conversar um pouquinho sobre lesões em rampa também. É uma pessoa que tem uma experiência muito grande, né, nesse tipo de lesão complexa e com certeza vai abrilhantar muito o nosso curso. So, Jorge, thank you very much for joining us in this course, and I'll let you do your presentation now. And after the presentation, we can discuss some cases. So, thank you very much for joining us.
Thank you very much for having me. My heart in pieces is in Brazil as well. As you guys know, we have 2 Brazilian fellows here at Rush now, and I'm really proud of our relationship with all my Brazilian friends, specifically you, Camilo. It's been a brother in all these scientific and academic endeavors. Okay, so let's get started. So I'm going to talk mainly about a special subset of meniscal tears, which are root and radial tears. So the surgical trends, at least here in the States, are very demanding. You can see that the repairs are going up by 17% and the meniscectomies are going down by 37%. This is an interesting slide considering that meniscectomies are still the most common procedure that we perform here in the States. And why is this? First, sorry, there's a lot of noise in the background. There we go. So first, it's very easy to perform. The second thing, it has a fast rehabilitation, and it also has low morbidity. If you think about return to sports, for example, a meniscectomy can go back at 4 weeks, and a meniscus repair at 8 months. And this is what happens to us, for example, when we're treating professional athletes, and they're getting paid millions and millions of dollars. They want to get back as soon as possible, and they truly don't care about what happens in the future. Same thing for revision rates. If you think about meniscectomies, the revision rate of a meniscectomy is 7%, whereas a meniscus repair is 18%. So it's almost 3 times more. So then why should we try to preserve the meniscus? Well, we can say proprioception, so you can avoid injuries, lubrication and nutrition, but mostly orthopods don't care too much about this. But when we talk about stability, this is probably something that we should consider. And we tested this in the robot. When you have, for example, a lateral meniscus root tear, you have increased rotational instability. And when you have, for example, a medial meniscus root tear, then you have increased anterior translation. And we've seen this, and you've seen this, Camilo, with all the ALL and LET work. When you have a medial meniscus root tear, then you have a significantly increased anterior translation. And how much is too much? For example, if you have a radial tear that extends all the way down to the meniscocapsular, and you take more than 46 or half of the posterior horn of the medial meniscus, then you're going to have an altered AP position and knee laxity. So taking half of the posterior horn, it's a lot. And this is similar to having an increased tibial slope. So it's basically having a predominant risk factor for having an ACL tear. But as you all guys know, the most important function of the meniscus is load transmission. And this is directly correlated with the amount of meniscus that we remove. If you remove too much meniscus, you're going to have too much stress. If you remove very little meniscus, then the contact stress doesn't rise so high. And this doesn't happen 5, 10, or 40 years down the line. It happens from the first year after the surgery. And you can see here in 3D gait analysis that you have an increased peak adduction moment and an increased flexion moment. This means that the load is going to go through the same compartment that you guys did the meniscectomy on from the first year on, and this can be objectively quantified. Now, if you wait for 10 years, you can see from this registry study, 2 out of 10 patients are going to come back to your clinic complaining about some sort of pain or any type of symptoms derived from the osteoarthritis derived from that meniscectomy that the surgeon performed a couple of years ago. Now, if you wait for 40 years, then you have 132 chances more of having a total knee replacement if you had a subtotal meniscectomy than if you didn't have one. So this is quite a significant change in the outcome of your knee if you do a repair versus a meniscectomy. And this doesn't only happen in old people. We looked at players in the NFL, and we saw that players that had only a 10% of their meniscus resected had more grade 4 condyle injuries, bigger condyle injuries, and also they had their performance outcome measures affected, meaning that they didn't play as many minutes as they used to play, they didn't start as many games as they used to start, and overall their passes and annotations and everything was significantly lower and poorer compared to what they had before the surgery. And these are the main thing that we need to talk to today, which are two special tears, the root and the radial tears. And we need to talk about this because we didn't use to fix them or recognize them. And the problem is that having one of these tears is basically like having no meniscus. Because we lose the hoop stresses, which are the stresses that the meniscus gathers when they have a continuity of the fibers from the anterior root to the posterior root. And these are very common. If you think about 10 patients are going to come with a meniscus tear, up to 20%, 17% to be more specific, have a meniscal root tear. And if you haven't seen them, they for sure have seen you. Because I'm pretty sure that you guys have seen this AVN in between brackets, because when you see this and you see that extruded meniscus more than 3 millimeters outside the joint, immediately you have to think about a root tear or a radial tear. In this study that we did with Andres Gomol and Bert Mandelbaum and Laprat, we basically found that 81% of a meniscus that had a root tear represented a SONC or a AVN of the condyle. Now, if you look at the total joint literature, you can see that 78% of the people that had less than 60 years old had a root tear that was unrecognized before, and this correlated significantly with the degree of osteoarthritis. Now, these are the things that we need to talk about today. Why to repair, the diagnosis, how to indicate the repair, how to repair, and which are the outcomes after a repair. So the why to repair is pretty simple. This is how a normal knee looks like when you have contact pressures inside the tibial joint, inside the tibial bone. But when you have a root tear, it's basically like having no meniscus. So you can see how the pressure changes when you don't have functioning meniscus, which is basically the same as having a meniscectomy. And this has been proven by Rob Harner. But look at this progression of x-rays. So this is the x-ray at 3 months after a root tear. That's 6 months, that's 9 months, and that's at 12 months. So when you think about this type of disease, they are rapidly evolving diseases. And therefore, when you think about patients that have been counseled to have a cortisone injection or treat this non-operatively, this might be something that can make that knee non-operative anymore if you wait for too long, because they can degenerate pretty fast. And this is the natural history. This was published by Aaron Critch from the Mayo Clinic, basically saying that at 3 out of 10 patients at 5 years will have a total knee replacement if they had had no treatment for the root tears. So it's a pretty significant contributor to degeneration within the knee. We did the study looking at the cost effectiveness of doing a meniscus root repair, and what we found was that it is a cost effective thing, because if you repair this meniscus, regardless of the fact that you're going to have to spend the money in doing the repair and booking the OR and all the cost associated with it, if you let that patient go with a meniscus root tear, that patient is going to develop arthritis, will need a total knee replacement in the future. So it is a cost-effective procedure. And the second reason is because you can restore the biomechanics of the knee. You can restore both the translation of the tibia. If it's the lateral meniscus, you can restore the rotational stability. If it's the medial meniscus, you can restore the anterior-posterior translation, but mainly because you can restore the hoop stresses. So when they ask you why should you repair, because you can restore the mechanics and also to avoid degenerative changes moving forward. And there are multiple studies now, both in the animal world and the clinical aspect of the studies, that say that you can actually stop or make those degenerative changes better. Now, for the diagnosis, you always have to suspect this type of tears in the right individuals. Usually, when you have a medial meniscus tear, you have a female patient that is usually overweight, Sometimes you have to think about skiers, plumbers, carpet layers, because they are kneeling quite a bit, or people that pray a lot. And also when you have a significant malalignment.
Excuse me, Dr. Chala.
Yes,
Your your slides down now. So I think for some reason we stopped sharing your screen just right now, this moment.
let me see.
So you can start sharing. Yeah,
Can you
that's
see now?
yeah, we're back. Just start playing your presentation. You're gonna be good.
Okay, so we were saying that female and overweight people usually are more prone to have this type of injuries, and also people that kneel quite a bit.
Trout.
Meaning,
É
I'm
sobre
sorry,
o que aquele porra daquele vídeo pro grupo.
O quê?
Foi o filho da mãe que viu aquele grupo, aquele vídeo horrível lá pro grupo.
I'm sorry, skiers, plumbers, carpet layers, and people that have significant malalignment. Now, for the history, 70% of those root tears are not going to be related to trauma, but they remember the starting day. They say, I remember that Monday when I had no pain before and I started having pain,
No grupo
where
da
I felt a
família.
pop.
É horrível.
And also in this patient, squatting reproduces the symptoms. And this is a very specific test that you can try in the clinic when they have a root tear, because this is going to extrude the meniscus. And if they have edema both in the femoral side and the tibial side, this can reproduce the symptoms. The physical exam is pretty inspecific, meaning that they can have joint line pain, meniscal extrusion, which is pretty hard to palpate when you're talking about 1, 2, or 3 millimeters of extrusion. But also you have to always look for concomitant injuries, because we know that, for example, lateral meniscus root tears are pretty much associated with ACL injuries. And this is what you see in the MRI. Again, when you see the extrusion of that meniscus for 1, 2, or more than 3 millimeters even outside the joint, then you have to think that something is going on. That might be maybe a root tear or radial tear in the back, so you have to go and look for it. And that edema that you can see there is an insufficiency fracture, it's not AVN. So that's why we need to be cognizant of this. Then when you go to the sagittal view, you can see that there's an anterior root, but there's no posterior root. And this is what we call the ghost sign. And if you're lucky enough, you'll be able to see the root tear in the axial view, as you can see it pretty clearly here. And then you can also measure it. We know by definition a root tear is a radial tear that goes from the attachment of a meniscus all the way down to 1 centimeter away from that root attachment. But this is important to know in the medial meniscus, because most of the times we're going to be able to see it. However, for the lateral meniscus, as it is so close to the ACL, 7 out of 10 patients of these injuries are going to be missed in MRI. And that's why you have to be prepared when you go to do an ACL reconstruction to probe this lateral meniscus and be prepared to fix it if it's torn. And this is an infographic that we just published in Arthroscopy, which basically outlines the indications for the root repair. So for conservative treatment, we like elderly patients and when they have significant osteoarthritis. Root repairs is for everybody else, so active patients with no significant arthritis, Kearney-Lawrence 1 or 2, and partial meniscectomy should be reserved for patients with symptoms that have no indications for repair. Remember that this is a time-sensitive surgery, that if you let this patient go 6 or 9 months, you might be at the time where you cannot repair this meniscus anymore. And this is a question that we also usually get into the podium. Does age matter? I have this 60-year-old patient that has a root tear. Should we repair it or not? And the answer is pretty clear. Outcomes are not correlated with age. So it doesn't matter if they're 60, 70, or 80 years old as long as they have good cartilage. So diagnosis and indications, again, always think about the risk factors for making a good diagnosis. Look at the history, when the pain started. If they tell you that the pain started just one day, that might be something that can lead you to the diagnosis of a root tear. A comprehensive physical examination is mandatory. In imaging, you can suspect the medial meniscus tear in imaging, but the lateral meniscus, you have to always be careful because you might not find it in the MRI, you might find it in surgery. And repair always when possible, when there is not too much osteoarthritis, such as Kearney-Lawrence 1 or 2. How to fix them? You have to basically recreate the anatomy. And for this, a good mnemonic is that you have to look for the tibial spine because that's the most clear landmark. For the medial meniscus, the attachment of the medial meniscus is 1 centimeter behind the medial tibial spine. And for the lateral meniscus, this is important, is 0.5 centimeter medial to the lateral tibial spine. And that's what you need to look for when you're reconstructing this root tears, because if you put the root tear where it doesn't belong, you can see in these pressure maps that you cannot reconstitute the hoop stresses or the pressure maps. And therefore, it's critically important to put those roots where they belong, to their anatomic positions. And this is basically a technique. You can do this with any type of instrumentation, but usually if you have curved shavers and curved curettes, that's going to simplify your work so you don't have to go and fight the spine. The other thing that you can do to facilitate exposure is sometimes grab a bone cutter and take, for example, that tibial spine, or you can do a notchplasty or a reverse notchplasty to be able to improve your visualization. Now we're doing more and more MCL pie crusting to be able to see very well in the meniscus. We know that the MCL heals, and we know that the cartilage doesn't. So if you have to take the MCL out to be able to get a good exposure and not damage the cartilage, you should do it. We are doing this more and more often, probably in 70 or 75% of the cases. Then we use this guide, which basically it's like an ACL guide that's going to guide a first, depending if you do 1 or 2 tunnels, the first tunnel to the back of the posterior root, and then a second tunnel that can be done with an offset guide. Usually we use 5 millimeters to go anterior to this. We have done a couple of biomechanical studies looking at 2 tunnels versus 1 tunnel, and there's no difference. However, we believe that if you have 2 tunnels, you can increase the area that is contact to the bone, and therefore you might have a better chance of healing that meniscus. So this is the second tunnel. They have a cannula that goes outside the reamer, and once you take that out, those 2 cannulas are going to remain in place and going to let you know where those holes are, and then you can bring the sutures through the posterior first and then the anterior so you don't have suture tangling. I usually like to use a cannula over the front so I don't get any soft tissue bridges. You can use a tape or you can use regular suture. We have seen in the lab that a simple suture is actually better than a tack stitch because it doesn't have too much of a bungee effect. And then again, you go on the posterior aspect of the root first and then the anterior aspect so you have a good grasp and you can secure it. There's some work from Korea which says that there's a zone which is 7 millimeters away from the root attachment. It's called the A7 zone, which is supposed to be the strongest portion of the meniscus. So again, if they ask you how to repair it, you just have to restore the anatomy regardless of the technique. You can use 1 tunnel, any type of sutures, and they should be just fine as long as you prepare the bed very well. And the outcomes are pretty good. You can see that Lishom, IKDC, and HSS, they all improve significantly, and they have a minimally clinically important difference when you look at the post-outcome measures for these patients. And do they heal? This study from Korea also looked at healing potential in second look arthroscopy and MRIs, and they said that 70% of them do. And the ones that do have better outcomes and less joint space narrowing. Which are the risk factors? Which are the patients where you should beware of repairing, or at least counsel the patients that those repairs might fail? When you have a significant malalignment, and also when you have too much osteoarthritis. And that's why when we are talking about the indications, we say patients that have Kerner-Norris 3 or 4 may not be the ideal candidates for this type of repairs. And this paper was just published in AGSM looking at partial meniscectomies for degenerative medial meniscal root tears that showed favorable outcomes in well-aligned non-arthritic patients. And we wrote an editorial commentary, basically, or a letter to the editor, saying that they had no control to say this. 32% of those patients were lost to follow-up. The failure was defined as total knee replacement and not decline in their outcome measures or persistence of pain. And also the alignment was measured in short films. So there are multiple flaws in this study that should be considered, and that's why I would tell you to beware of reading papers like this where you are basically biased by what they basically report on. How about early rehabilitation? So can you make these patients walk or partial weight bearing after the surgery? This study showed that there's a significant unrecoverable loosening from rehabilitative loading at the beginning. So if you don't let these patients heal, these patients are going to displace, and that's not recoverable. So those patients are not going to do as well. So non-weight bearing for 6 weeks is probably the best way to go and the safest. So for the repair outcomes, good functional outcomes can be expected, less joint space narrowing, and also less conversion to total knee replacement. Now let's talk about radial tears. Radial tears are like the sisters of root tears because it's basically the same. It's like having no meniscus. This is more common in active patients and more frequently appears with ACL tears or multi-ligament injuries. And this is what we see in the MRI. It's basically the same as having a root. You can see a truncated triangle sign. You can see a cleft sign. This is a marching cleft sign when you see it in multiple axial views. And this is a ghost meniscus sign when they are separated away, and you can see it on one spot and you can't see it on the other one. The historical resolution for radial tears was a partial meniscectomy where you would eat a piece of the border of the posterior and the anterior leaves. That would give you short-term relief with a low level of complications. However, they would have accelerated cartilage wear and high reoperation rate moving forward because they would have significant degenerative changes. So after doing side-to-side sutures, which were not very helpful, or which were not very successful, Nakara and Shino in 2012 developed this technique, which basically consisted in putting initial vertical sutures in both sides of the menisci, and then horizontal sutures outside the vertical sutures. So using those sutures as a ripstop. They evaluated 27 patients with second look arthroscopy, and 19 of those patients completely healed. So although it was better than what was previously reported, this is not ideal. So the development of a novel repair technique, because the current techniques do not reduce the edges, they try to basically put those edges together, but they're not completely reduced. And why not to treat them like two root tears? So basically doing a tunnel and bringing those leaves through the same tunnel and crisscross the sutures on each end. And this is how the repair looks like. And the biomechanics for this type of repairs show that when you do a transtibial tunnel on top of the common repair, you have 2 times less gapping and 2 times a stronger failure load. So this is probably the way to go if we're trying to keep this meniscus healthy for as long as possible, mainly in heavier individuals. The outcomes for this, we have reported this in AGSM, 27 patients, 3.5 years follow-up. We can see that the lesion improved from 47 to 91 post-op. There's no difference when compared to an inside-out vertical longitudinal tear repair, which is probably the gold standard for repairs. So you can see how by putting those sutures through the tunnel, they don't look that they're inverting onto the meniscus. And the other thing is you can restore the rim of that meniscus, which is what you want to do in order to restore the hoop stresses. So when we think about the rehabilitation, we like to use the periodization concept where you basically work on range of motion first, endurance second, strengthening, and then power at the end. For range of motion, we don't like these patients to get stiff, so patellar mobilization and flexions from 0 to 90 is completely encouraged. However, we like, as we said before, to remain non-weight bearing for 6 weeks. So we usually divide meniscus repairs in 2 groups. If you had loosening of the hoop stresses, meaning that you had a radial tear, or if you have a root tear, those patients are non-weight bearing for 6 weeks. If you have a vertical tear, a ramp lesion, or one lesion that's going to get reduced with a weight bearing, we let those patients weight bear right away. Endurance and strengthening can be started at 6 weeks with partial weight bearing, stationary bike, no pivoting activities, and leg presses to 70 degrees. Power is the last phase that starts at 4 months with running progression, agility, and a sports test at 6 months to see if they can go back or not to sports. So in conclusions, for root and radial tears, always suspect them. MRI is not definitive, mainly for the lateral meniscus when we're thinking about a lateral meniscus root. Fix them when the cartilage is acceptable, Kernonis 1 and 2. We are now trying to pushing our indications because we're seeing that these patients, even with Kernonis 3, or when you see those big focal condyle defects, do better because their knee swells up less, because we can take a little bit of the pressure out of the focal condyle defect. And outcomes to be expected are really good or excellent, and you can actually prevent joint space narrowing. Thank you very much.
Thank you, Jorge, for your great presentation. We have a few questions for you.
Sure.
And one question is from São Paulo. Is if you always request post-operative MRI to check your root repairs, to check the healing process. How do you do it? It's only clinical, or you normally request any exam to check it?
I never get MRIs post-operative of root repairs because you might see that there's edema, you might see that the radiologist can inform that it's still torn or there's like fluid in between the repair, and then the patients might get scared. So it's pretty tricky. So for me, it's clinical. If the patient is doing well, there's no need to do an MRI. We can do it at 1 year follow-up. For example, if those patients are still in pain, if they went back to sports and they feel if they do feel mechanical symptoms, that's the time when I would order an MRI sooner rather than later. But if not, I just let the pain guide how much I ask for or not. If the pain is gone, then that's all we need to do.
Okay. We are doing some research regarding post-operative MRI, and we see there's the healing tissue. It's not low sign every time, even if the patient's
Yes.
doing pretty well. So the radiologist they put in the report, oh, there's a partial healing, and we don't know if the imaging healing is as good as we want it to be, but normally if the patients are doing fine, we let them return to sports and everything.
I think that's smart. And as you know, here in the States, we practice a pretty legal defensive medicine. So having MRIs that say they're not healed it's a pretty important liability issue for us. So we try not to order too many MRIs if we don't need them.
Okay. Regarding chronic root tears, do you use any threshold to indicate the repair? And what do you do what are the strategies to reduce the extrusion, to put the meniscus in the correct place?
That's a great question, Camilo. So first is how do we repair those? Well, the indication again for root repair is not having too much osteoarthritis. So regardless of the fact, and we looked at our clinical outcomes, and what we saw is that it doesn't matter if it's acute or chronic, those patients do better. The more duration of the symptoms that they had, the less better they do, but they still do better. Now, it's an interesting question because when you have a chronic tear, that's going to be completely adhered to the back and the capsule, and it's really hard to bring it all the way back. So what we do is basically take a scissor, an arthroscopic scissor, to the left or to the right based on where the meniscus is, and then we section the meniscocapsular attachment all the way down until we can go all the way down to the MCL, if it's a medial meniscus, to be able to bring it back down. Those meniscocapsular injuries that we create are going to heal. We haven't had any problems with that. I think Laprada was going to report on that as well. He hasn't had any problems, but we do have problems if we don't bring the meniscus to the anatomic location. So I would encourage you, if that meniscus is not coming and it's under a lot of pressure, just cut the meniscocapsular aspect of the meniscus all the way down to the MCL and bring it back down to its anatomic position.
That's the way we do. But I always question the other guys from our group if we need to put sutures in the posterior horn after we reattach the root. When we do these big releases, sometimes I feel that I could put some 1 or 2 or maybe 3 sutures in the posterior horn after we do these big releases. What's your opinion? Do you put sutures or you just reattach the root?
We do not put sutures. It's a good question. From an anecdotal experience, I can tell you we haven't had any problems, but that's something that it's worth studying, if you need to put sutures or not. They might heal because it's acute and it's in the meniscocapsular, but you're basically creating a round lesion.
We have another question here. Do you have cases in which you had to associate an osteotomy with your root repair? For example, a slight varus, so you do the medial root repair and you do open wedge high tibial osteotomy as well, or no?
Yes. So for the patients in the chronic setting, when these patients are still symptomatic and the cartilage is not too far gone, you can do both procedures, one to protect the cartilage, to protect the repair, and also you do the root repair at the same time point to be able to try to save that compartment. As you know, this degenerates quite quickly, So if you let this patient go for 6 months, it can go from a caregiver endurance 0 to a 2. And in those cases, I think an osteotomy, when you have significant malalignment, remember that we said that one of the risk factors was more than 5 degrees of malalignment. If you have more than 5 degrees of varus, that's a patient that you should indicate a concurrent osteotomy with it.
Okay.
Camilo, can I ask a question?
Yeah, you
Yeah.
can go ahead.
Dr. Chala, for this
Yes.
big MCL release that you do, sometimes that are necessary, does any time you protect the MCL after surgery?
I don't. Well, they're protected on a brace anyways because they're locked in extension. So I don't protect the MCL as they have to be non-weight bearing for 6 weeks. The MCL, we haven't had any problems with the MCL, and there are some literature from the total joints people saying that bycrusting the MCL or even taking it out doesn't produce any type of symptoms afterwards. We're not
And
very
for how
concerned.
long? And for how long do you keep them on a brace?
Depends on the patient. We usually keep them for 6 weeks. So we use a hinge brace, and we keep it locked for 2 weeks, and then they can unlock it to 0 to 90. What you don't want to do is have more than 90 degrees or weight bearing in lower flexion angles, because that's what brings the most stress to the meniscus. You want to limit their flexion to not over the 90. 90 should be the maximum for at least 12 weeks.
Yep.
Okay. We have another question here regarding the root tensioning.
Mm-hmm.
You normally hear when you reattach the roots,
Yes.
do you tie it over a button with maximum tension? How do you do?
So I tie it over a button with as much tension as I can without killing it at 90 degrees of flexion, because in that way you assure that that patient can move 0 to 90 without any problems and without the sutures breaking. The other thing is that you have to always look at the tissue quality, right? Because if you know that suture is going to come out, you rather that suture come out in the OR when you're there and you can put another suture than at home. So always try it out. Try to be as comprehensive as you can. And as you can see there with the probe, you have to test it. You have to make sure that that root is not going to go away. Because if that thing moves, then it's not going to heal. If you have a motion of more than 2 or 3 millimeters, that's not going to heal.
I normally tie over a button as well, but sometimes for overweight patients, we have some difficulties because we have to do like a large incision to do that,
Yes.
and the fat tissue disturbs a little bit. Do you have any tip regarding that, or just do a bigger incision to see it better?
So I'm not, here in America, we're not very scared of bigger incisions. In Europe, they're more aesthetic, let's put it that way.
Okay.
But here, I haven't had any patients complain about the incision. I guess the other thing you can do is probably use a biotenodesis screw, such as a swivel lock or something of that nature.
Okay. There's a question regarding meniscus centralization. Do you do that? Do you put a suture in the meniscus body and try to do this centralization thing? What's your opinion regarding that?
That's a great question, and a study I wanted to do. I told the study idea to Alan Gaywood, and he published it already, so I'm pretty pissed off every time I hear something about it. So basically what he showed is that by putting one suture, well, and it's the same question for transplants, right? Like, should we put another suture or another anchor in between the 2/3 to be able to anchor it back to the tibia? And my rationale says we should, but what they showed in their study was that it was no difference when they put another transtibial tunnel. So they did 3 transtibial tunnels, and basically it was the same. It does make sense in my mind, so probably when I study it in the lab, probably I'll have a clearer answer for you.
Okay, thank you. Do we have more questions?
I have one more question. For
Okay.
radial lesions from the meniscus, when you use the tunnel technique, do you associate like inside-out sutures also?
Yes. So I do the same thing. I use ripstop sutures. I'm sorry. So vertical sutures on the sides, and then horizontal sutures outside those vertical ones. And then I just do like the same thing like you would do for a root repair. So you do both. And then I've seen a couple of second look arthroscopies after this repair where I thought that tissue is going to be basically going down to the tibia and intruding into the tibia, but they do not. For some reason, they are like if it would be like a normal meniscus.
Thank you.
Here in Brazil, we don't have all the devices available, all the new devices to radial tears or root repair. So sometimes we have to improvise the technique. For example, we still don't have the meniscus root repair kit here. So we normally drill the tunnel with an endobottom drill. So it's 4.5. So it's too big. I think, in my opinion, it's too big to do two 4.5 tunnels to do the reattachment. So we normally do with only one tunnel, even though we know that two tunnels would be biomechanically better. But one tunnel is working so far until we have it available. So that's one disadvantage we have here, because we don't have all the devices quickly. Sometimes it takes a while to get here. So
And I'm from Argentina, so I'm very well aware.
You know.
I know very well,
You know.
yes. So I think what we saw in the lab is that doing one or two channels is basically the same. We think that doing two channels might increase the area of the surface of healing, so we believe it can be better, but biomechanically they're the same. As long as you can put it back into the anatomic location, I think it's fine. And then when you don't have the right instruments, you always want to try to make sure that you can see very well, because the main problem of this surgery is not being able to see. So if you don't have the curved curettes or you don't have the curved shaver, then make sure that you get a bone cutter, take some of that tibial spine, or do an archplasty or reverse archplasty until you can see that pretty well. And then if the space is not the right space, just do an MCL pie crossing until you can see it. I think, it's the key. The instruments, I think you can get away with an ACL tibial guide, and then just do a 4.5 as you guys do, and then tie over the button. I don't think it makes too much of a difference, to be honest.
How often do you have to remove the tibial spine? How often
Not
you
too
do
often,
that?
because I try to make my portals as high as I can.
Mm-hmm.
When I'm looking for it, I always try to do a diagnostic arthroscopy as fast as I can with just one portal. And then if I see that there's a root, then I try to make that portal as high as possible. And then if I can't get there very well with a straight shaver, I can open a curved shaver, and that makes it easier. And we have the curved curettes and things of that nature that makes it easier to prepare. Now,
What about
there's a new first pass zone specific from Smith and Nephew, which basically have it's like a first pass or a knee scorpion that has a side tilt, right? And that makes it quite easy, or easier at least, to pass the sutures to the meniscus.
what about between the use of wires or tapes? Like, what's your preferred option now?
I usually just use sutures, fiber wire or Ethibond. I don't like to use tapes just because I haven't used them before and I don't feel comfortable as of now. And there's no studies looking at that, so I think we just have to wait for other biomechanical data or clinical studies showing that one is better than the other.
Okay. Do we have any more questions? Okay. Jorge,
Yes.
do you want to show? Do you have any case you want to show? Do you want to
We can go
discuss?
with your cases, guys, if you want to.
That's awesome.
Okay, I'll show one case and then we
Okay.
can discuss a little bit. Okay.
Perfect. Let's do that.
Okay.
I'm going to stop sharing my screen.
Okay. Bonadil, consegue ver minha tela?
Sim.
Ok.
Então
So,
coloca no modo apresentação.
não foi?
Não.
Tá, né? Não?
Tá meio travado.
Ué, tá. Oi?
Não.
Ué,
Você tá. Tenta parar
pra mim
de.
aqui tá.
Tenta parar de compartilhar e volta a compartilhar de novo só pra gente testar.
Peraí. Foi agora
Coloca
não?
no. Não, cara, tem alguma coisa errada no seu computador.
Ué, assim você tá vendo ou não?
Eu tô vendo. Assim eu tô vendo a sua tela. Mas eu tô vendo
Tá,
os
tudo bem.
slides do PowerPoint montado.
Não, tudo bem, a gente vai passando assim então.
Tá bom.
Ah, Jorge, I will speak
Yes,
in
sir.
Portuguese just for the audience, okay?
Of course.
If you need,
I think I
I
think
know
I'll
your
understand. If
I
you
know
speak
your
slowly, I'll
Portuguese is
understand.
very
You can try your Spanish, Camilo.
good. No, my Spanish is not that good, I think. Só um paciente masculino de 19 anos, jogador de futebol, teve um entorse de joelho durante uma partida e estava com uma dor medial e dificuldade para marcha. Então, ao exame físico, ele tinha um derrame articular importante, não tinha instabilidade anterior nem posterior e tinha um estresse em valgo, duas cruzes em três, bastante dor na interlinha medial, com testes meniscais positivos. A radiografia era normal e esse era o exame de ressonância magnética. Tá? Então,
I mean, we can't see the presentation. Is that okay?
you can't see?
I just can see one slide.
Exactly. Só tá mostrando um slide, cara. Você mudou o slide?
Bonadil, vai comandando uma discussão aí, eu vou tentar sair aqui e ver o que está
Não, cara, eu acho
acontecendo.
que só. Para de novo a sua apresentação. Você tá colocando para compartilhar a sua tela ou você tá compartilhando o aplicativo?
Não, estou compartilhando a tela. Agora você está vendo ou não?
Sim, tenta colocar em outro slide.
Ó, mudei.
Não tá
Foi?
funcionando. Não, tá
Então,
travado em um slide.
comanda a discussão aí. Eu vou tentar sair aqui do aplicativo e entrar de novo.
So Camilo is logging out and in again just for a few minutes. Mais alguém tem alguma pergunta, pessoal, aqui no chat? Mais alguma dúvida? Dr. Chala,
Yes.
regarding the quality of the meniscal tissue, like do you think there's some, like when you decide not to repair the root, based on the quality of the tissue?
So sometimes if I see that the side that was detached doesn't have good quality, you can actually bite that down until you have good quality tissue. As long as the cartilage has good quality tissue and you have not too much arthritis, then you can still repair that. So sometimes you have like a very edgy, a very like I don't know, not very quality edge of the meniscus. You can trim that down until you find good quality. Again, as we said before, there's some studies from Korea saying that 7 millimeters away from the root attachment, that's probably the strongest portion of the meniscus, and that portion is usually pretty well preserved. So I would try to go more medial rather than lateral because you are at risk of having a pull through the tissue, if that makes sense.
Yeah, Zach. I think Camilo is coming in. Yeah.
Consegue me escutar, Bonadil?
Sim.
Dr. Chala, good
Yes.
night.
Good night.
I have some questions for you. You said that you tensioned
Avoid this?
the repair at 90 degrees of flexion, right?
Yes.
Do you think that when you move through extension, for example, the tension in your sutures they change? Uh, that image that you show testing the tension of the repair, it is at 90 degrees of flexion or is near extension?
No, that's at 90 degrees of flexion. I don't think it'll
Okay.
change much because it's not that you're going from one bone to the other, so isometry doesn't work here too much, and therefore I think 90 degrees is the safest because you know that that patient is going to be able to get to 90 degrees at least.
Okay. And do you think that when you do medial release of the MCL, do you think
Yes.
it may change your results after a uni if you need to do a uni after? For example, would you do an Oxford uni with after doing a medial release or pie crusting?
Yes, I think the MCL heals, and we've seen that over and over. Those patients do not have instability. And then if you think about it, or if you examine those patients at 12 weeks, they have no instability whatsoever. So doing a uni in a patient that had, hopefully you won't have to do it because you did the root repair, but if you have to do it, that should be like a primary. It should be pretty much the same.
And how long do you use a brace? Because I saw that patient, he was in rehab, and he was with the brace at 4 months of rehab.
Yes,
So how long do you use a brace?
that patient was a multi-ligament injury, so that he had ACL, PCL, post-lateral corner, and a root tear. For those cases, we usually use it for 6 months. So the PCL dynamic brace, the other one, we keep it for 6 months. And then at 6 months, we do stress x-rays. But that's a special case. For root tears, we tend to keep it for 6 weeks. 2 weeks is locked and 4 weeks is non-locked. And we only want to restrain flexion over 90 degrees.
Okay, I think Camille is ready now.
Now we can see it,
Bu-
Camilo. Thanks.
Bonadil, tá ok? Tá
Tá ok.
passando agora?
I have one question here. It says, which technique do you use for pie crusting? Aguja, na interlínea percutánea.
A
Yeah.
needle in, yeah.
Yes, I got it. It's a needle.
Okay.
I use a needle. So you want to try to go a little bit more posterior than the MCL because, as you know, the posterior medial capsule is what restrains the valgus gapping in full extension. So I try to go in the posterior medial aspect of the MCL, and I don't want to see the needle. I don't need to see it. I just go multiple times on the femur until I hit the bone, and then I'm doing valgus stress until I see that the space has opened. I'm using now
Okay.
the spider, you know, the like the pneumatic arm from Smith and Nephew that people use for shoulders.
Yeah.
I know.
Yeah, I'm
You're
using that
using
for
it?
the bone.
Okay. We don't have it here, for example.
It's good if you don't want to have an extra hand that can help you. I don't know, put the knee in extension or flexion, or just keep it in the same spot. It's actually pretty good to do that way.
Yeah.
Ok, so, pessoal, a gente teve um pequeno probleminha, mas acho que agora está recuperado. Então, paciente de 19 anos, teve um entorse de joelho, dor medial, tinha um derrame articular, não tinha instabilidade anteroposterior, tinha um estresse em valgo com uma dor na interlinha medial e testes meniscais positivos. Esse era o exame, o raio-x dele era normal e esse era o exame de ressonância magnética, né? A gente vê que na topografia da raiz posterior do menisco medial, esse paciente ele tinha uma lesão da raiz, né, uma anormalidade da raiz, associada com uma lesão do colateral medial, né? So, Jorge, how often do you see these ipsilateral lesions, MCL plus medial meniscus roots?
It's not that common, to be honest, unless it's a multi-ligament injury. We usually see it in medial meniscus roots is usually associated with traumatic or not traumatic. It's a patient. It's a 40 fat female. That's what we say usually for the medial meniscus. The lateral meniscus is usually more traumatic, and it's associated mostly with ACL tears. But this is not a very common injury. This will make you suspect if it's the meniscofemoral, meniscotibial ligaments that are completely detached, and that's why it's so extruded, or it's actually the root or radial tear on the back.
Então essa não é uma lesão comum, essas lesões ipsilaterais do menisco medial com colateral medial. So it's a grade 2 to 3 MCL tears associated with a medial meniscus root tear in a 19-year-old football player, soccer player actually. So what would you do?
This is a good case. So I think the good thing about this is that your meniscal root repair is going to be really easy in this case. You won't have to do much. So from that standpoint, I think I would do that. And then, to be honest, I would repair the MCL, because what I've seen is that when they are there's a new score to grade the MCL tears, and they say that if it's separated for more than 1 centimeter, it seemed there that it was pretty detached from the femoral side. Those don't heal as well. So probably just doing an augmentation with hamstrings, just keeping the hamstrings attached distally and doing an augmentation on top would be the way to go for this patient.
Great. Gobi, Bonadil, vocês querem fazer algum comentário?
Não, acho que não.
What would you do, Camilo?
Oh, I did the same. I did a meniscus root repair and a MCL repair associated with augmentation with hamstring tendons, keeping it attached. So exactly the same. So this is not the same case, but just to illustrate the reconstruction, we normally keep it attached and we do like a V reconstruction, similar to the lean technique.
Yeah. So let me play devil's advocate here, because I'm sure that people might be asking, why not just do the root repair? And then if you guys are pie crusting the MCL anyways, like, why don't you just let the MCL go? What would you say to that?
Well, I would say that in a 19-year-old soccer player, I would not believe this healing process, you know. And I normally don't do isolated repairs for MCL. I always augment with hamstring. So I don't believe in the isolated repair if you indicate surgery. I don't know how you do if you do isolated repair for MCL tears, but I don't think we get the good fixation only with the repair.
I would agree with you. The only
Especially
caveat with this type of repair, Camilo, is that when we try this in the robot, it's so anisometric that it would basically jump and break the graft every time we try to do this. Imagine that the robot is like a physical therapist from hell, where you basically put the patient through the most exhaustive physical therapy day one after surgery. So I think that this is probably one of the best repairs that there is, but the only change that you have to do is change the insertion. So we usually put anchors on the back of the tibia to posteriorize the insertion of the MCL, and then we bring it to the front, to the femur, and then we bring it down to the POL portion. If you need to, you can just leave it in the femur. So always posteriorize the insertion. And I was with Martin Lind this weekend in a course, and we were talking about this, and he basically does the same now. So he doesn't use this technique anymore.
He doesn't use it?
He does the technique, but basically posteriorizing the insertion. He puts two anchors on the back of the tibia, ties both the gracilis and the semitendinosus, and then he whip stitches that, and then goes to the femoral tama.
Okay. So I did the repair. This was my first root repair. I will not show the whole video, but this is the root here. So we did some debridement over there, and we as I told you, we didn't have the knee instrument, so this is a shoulder device to do the repair. So it's a little more difficult because it's pretty big, but we could do it.
Gladly, yeah,
So
an MCL tear too.
yeah, of course. So as you told, you have to deattach the roots so you can put in the correct place.
That's great.
And well, then you do the tunnel with the ACL instruments, and you just put the sutures inside the tunnel, and you can tie it in a button or an anchor and whatever.
Nice.
So this is the 1 year post-op MRI showing the root is in place. We could reduce the extrusion, and we have good healing as well. And this is 2 year follow-up. So the knee is pretty intact, so the result is pretty good.
That's
And
phenomenal. That's really good.
and this is the physical examination showing the MCL healed as well. We are 4 minutes away from 9 p.m. So I would ask you if anyone has any more questions.
There's one question. If they want to know about the meniscal extrusion and like how long you do the suture, like after if you have already the meniscal extrusion, for how chronic do you repair this kind of lesion?
I don't think it matters how chronic they are. I think it matters more how the cartilage surface is. So if the cartilage surface is okay, then I don't worry too much about how extruded the meniscus is, if that makes
And
sense. But as Camilo
do you
did, when you have significant extrusion and then it's chronic, then you have to go ahead and just cut all the meniscocapsular aspect of the meniscus until you can get good motion of that meniscus to go back to where it belongs.
you guys are using ultrasound for measuring extrusion?
No,
No.
no, to be honest, just the MRI. The problem is that if you
Uh,
use ultrasound, it's great, but it's a time-consuming thing. You have to basically bring the ultrasound to that patient's measure, and it takes quite a bit of time, so it disrupts the clinic flow quite a bit.
do you think the extrusion correction is necessary for a good result, clinical result, or not?
We don't know the answer to that. We know that at least for the transplants that we have some data for, extrusion was not correlated with good outcomes or decrease in pain or subsequent surgery, meaning that extrusion did not matter for some reason. It would make sense that it would, but it doesn't, at least in the meniscus transplant data.
Okay, so Jorge, thank you very much for joining us. I know you have a very busy schedule, so we appreciate a lot your participation here, and I hope we can count on you for future courses as well. And thank you for joining us today, my friend.
Of course, it would be it was my pleasure. You're a great friend and a leader in the field, Camilo. So I'm happy to participate, and I want to invite everybody that wants to come here and visit and just have some good dinners and see the Chicago River anytime. You guys are always welcome. Hope to see you guys soon in
Okay,
Brazil.
Thank you.
hope you. Thanks, man.
Thank you, guys. Bye bye.
Pessoal,
Bye
vou
bye.
encerrar a aula. Essa aula a gente também já foi gravada, a gente vai disponibilizar ela gravada online. Eu vou tentar tornar isso um pouco mais rápido. Essa semana a gente teve um problema, por isso demorou um pouquinho para a gente colocar a segunda aula, mas eu acho que essa vai ser um pouco mais rápido. É isso. Boa noite para todos. Até logo.